Hello, so now I'm going to condense a review of the cerebrovascular disorders, which is mainly just strokes. Most of my condensed material is over ischemic stroke, and then there will be a short portion on hemorrhagic stroke. That is because 80% of strokes are ischemic and only 20% are hemorrhagic. So through our career, we will see many more ischemic strokes than we will hemorrhagic strokes, but I'm still going to cover that material, just not quite as in depth. There's not as many steps to take with the hemorrhagic stroke treatment. All right, so let's get started. First of all, we're going to talk about signs and symptoms of a stroke. We've got a headache, mental changes such as confusion, disorientation, and memory impairment, decreased respirations. This is due to decreased neuromuscular control. So moving on, cough and swallow reflex will be decreased. Agnosia, which is the decreased ability to interpret sensations. Then we also have incontinence, seizures, hemiparesis or hemiplegia, emotional lability, visual changes such as hemanopsia, Horner syndrome, which is ptosis of the upper lid. To clarify, that's like their one lid will be like this, or the other lid. Either way, one of them will be drooping. Possible vomiting, perceptual defects, and then apraxia, which is the inability to perform learned movements. So now we'll talk about risk factors. Age is a major risk factor. Your chance of stroke increases by a large percent every year that you are alive, over 50, I believe. Hypertension, atrial fibrillation, high cholesterol, this leads to plaque buildup, which can lead to a stroke. Increased insulin resistance, because it leads to stiffening of your vessels. And then obesity. Obesity typically indicates a sedentary lifestyle, which increases your risk of clotting, because you're not moving around as much. So now we will specify right versus left signs and symptoms. So if your stroke occurs in the right hemisphere of your brain, you're going to have left-sided paralysis or weakness, spatial perceptual deficits. They will minimize their problems, have a short attention span, visual field deficits, impaired judgment. They'll be impulsive, and they will have an impaired concept of time. For the left hemisphere, you will have right-sided paralysis or weakness. Then we're looking at impaired speech and language, slow performance, also having visual field deficits. But these patients will be aware of their deficits, and this might lead to depression and anxiety related to their situation, and then impaired comprehension of concepts, words, things like that. So now we're going to talk about the pre-hospital stroke scale. I think it's actually called the Cincinnati pre-hospital stroke scale. It consists of 3 things: facial droop, arm drift, and altered speech. Basically, if any one of these things is abnormal for your patient or your loved one, then their risk of actively having a stroke is greatly increased, and you need to take them to the hospital right away. When they get to the hospital, we're fixing to discuss nursing responsibilities, assessment, and diagnostics that need to be run in an extremely quick fashion. So, time. We need to know when they were last well. Time is also a major factor. We need to do everything as fast and as efficient as possible while still being thorough. Then we're going to do a focused history. Have they had surgeries recently? What kind of meds are they on? Do they take any anticoagulants? And then do they have a history of aneurysm, ICH, or AVM? Those are really important, especially if they're having an ischemic stroke, okay? Then we're also going to do the NIHSS during that time. Then we're going to send them off to CT. First, we're going to get a CT without contrast to check for hemorrhage. If it's negative for hemorrhage, we're going to get a CTA, which is just a CT with contrast, to check for the location and the size of the embolus. Because of the CTA, they will decide either TPA or surgical intervention, which is basically clot retrieval. This needs to be done within 20 minutes, especially the first CT. It needs to be done within 20 minutes of their arrival to the emergency room. Then we're going to do an EKG. This is checking to make sure that they're not having an MI. Then for our lab work, we're going to get a glucose, CBC, CMP, a PT, INR, and cardiac enzymes. All these things are to rule out other problems that could be occurring, but also to check our blood coagulation levels in case we do end up giving TPA. So now we're going to talk about nursing management. The airway, always check your patient's airway first. Always remember your ABCs, airway, breathing, cardiac. So then we're going to do the cardiac monitor. We're going to put our patient on telemetry. We need to know what their heart is doing, okay? Blood pressure, we're going to try to keep their blood pressure below 185 over 110. That's the maximum amount allowed before you give TPA. And our drug of choice to control blood pressure in stroke patients is labetalol. So then monitor for hyperthermia and treat it with antipyretics such as Tylenol. Hyperthermia can exacerbate the stroke and make everything much worse than it already is. All right, so moving on. You've done all of your CTs, you have all of your lab work back, your patient is not hypoglycemic, their PT-INR is all within range, they're not having an MI, they're not hemorrhaging. So the clot is small enough that we're going to break it up with TPA. So what this means, TPA is an enzyme that we inject into the bloodstream. It restores blood flow and reduces infarction volume. The indications to give this med are that the CT is negative for hemorrhage, the blood pressure is under 185 over 110, and the glucose is between 50 to 400 milligrams per deciliter. They also have to have a diagnosis of ischemic stroke with neurological deficits within the previous 3 hours before administration. So for dosage, it's always the same and it's on the box. It is 0.9 milligrams per kilogram. You're going to give 10% of that dose as a bolus. And then the remaining 90% of that dose will be infused over an hour. Then how do we know what we're supposed to, who qualifies, who gets this drug? So they have to be over 18. They cannot have had head trauma, MI, or CVA within the last 3 months. They can have no history of intracranial hemorrhage, an AVM, or an aneurysm ever. No GU or GI bleeds within the last 3 weeks. No major surgeries or traumas within the last 2 weeks. No ART sticks or lumbar punctures within the last week. No heparin administration within the last 48 hours. It's preferred that they're not pregnant, but that comes down to a risk versus benefit scenario and is different with every doctor you meet. And then we're going to look at their med list. If they're on any direct thrombin inhibitors or taking the factor XA, they cannot receive TPA because their blood's already too thin. So the major potential complication that comes with the administration of TPA is hemorrhagic conversion. So 6% of patients that have received TPA have had a hemorrhagic conversion within the 36 hours of administration. This presents as hypotension and hypoperfusion. So now we're going to talk about what we as nurses do for this drug from start to finish. First, we're going to review the criteria. We're going to make sure that our patients meet the criteria, have all the indications, have none of the exclusion factors active. Then we're going to get consent and education. Consent isn't always something that we can do, especially if they're mentally altered, which is highly likely with a stroke. But we do need to educate the family and the patient on what's going to happen, what could possibly happen, and how we're going to go about this. We need to start 2 large bore IVs, 20 gauge and up. The TPA needs its own IV line. That's why we're starting 2. Then we're going to admit this patient to the ICU. We're going to do neuro assessments and blood pressure monitoring. So our neuro assessments are going to be every 15 minutes for the first 2 hours. Then they're going to be every 30 minutes for the next 6 hours. And then they're going to be every hour for the remaining 16 hours, okay? If our patient is having any adverse signs of this drug during administration, you're going to stop it, just like you would any other drug. Just stop it, hold, and call your physician. After administration, we're delaying line placement. We're not placing an NG tube, a Foley catheter, an ART line, because our patient's blood is so thin that if you cause any trauma, it can cause a hemorrhage. Then, once they're feeling a little better, we're going to do a bedside dysphagia screen just to see how they're swallowing and all that is going, okay? And last but not least, within 24 hours of administration, we're going to follow up with another CT. This is checking for hemorrhagic transformation. It's also checking to make sure that the embolus has been resolved. So, if your patient does not qualify for TPA, but is having an ischemic stroke, we have 4 different surgical options that we can do. We have arterial thrombolysis, which is you go in through the femoral artery all the way up into the brain where the clot is, and you inject just the clot with TPA, and it busts it up, breaks it down. Then we have an embolectomy. This is very similar. You enter through the femoral artery, the microcatheter goes all the way up into the brain, finds the clot. It has a little screw on the end of it, and it screws into the clot, and then they pull the clot out with the catheter. It's called clot retrieval. Then we have the carotid endarterectomy. These don't happen as much as they used to, but they will slice open your carotid, hold it open and pull the plaque out of your veins that way. And then we have the angioplasty, which is a stent placement, femoral entry, and they go in, they put a stent in the middle and open it up. You're almost done, guys. So now we're going to talk about hemorrhagic strokes. We have intracerebral hemorrhage and we have subarachnoid hemorrhage. ICH is in the brain, and the SAH is between the brain and the skull in one of those layers that protects the brain. So ICH accounts for 41% of hemorrhagic strokes and commonly results in hydrocephalus afterwards. And SAH is typically caused by an aneurysm rupture. The people most at risk for this are women, smokers, and people with hypertension. So the treatment for this is they're going to do a craniotomy, they're going to open the brain, and they're going to evacuate that hematoma. And then they can do some other things such as aneurysm clips to clip the vein off so that it stops bleeding, or the coil, which is a microcatheter insertion, coils into the aneurysm that has not burst yet and encourages the blood to clot. There's some really specific science there that I'm not going into. Then we have nursing actions after their hematoma has been evacuated, okay? So we have vasospasms. That's what we need to watch for. It's a narrowing of the cerebral vessels that causes ischemia. So you could recover from your hemorrhagic stroke to turn around and have an ischemic stroke. And we just really don't want that to happen. So we're going to treat them prophylactically with calcium channel blockers for 21 days because this has shown to reduce the occurrence of vasospasms, okay? And then we're also going to give them volume replacement to replace that blood that they lost into their brain, also to combat the blood pressure lowering effects of the calcium channel blockers because we don't want to bottom them out. So as I said before, hydrocephalus is a super common complication of ICH strokes. So if this occurs, they're going to place a drain. Once they place that drain, their cognition should improve dramatically. So now we're going to talk real quick about a swallow study and what we as nurses are supposed to do with it, and then we're all done with cerebrovascular. So during the swallow study, before we even start, we're going to auscultate their lungs and evaluate how they follow commands. Okay, if they can't follow commands or if their lungs already sound pretty wet, probably not going to do this. I'm going to give them time to heal first, and then we'll come back and try again. So after they've taken their first sip, we're going to monitor for coughing. If they start coughing profusely right after they take a drink, this is indicating that it's not going down the right pipe, okay? Then after they finish coughing, we're going to auscultate their lungs. We're going to make sure that this, in fact, did not or did go down the wrong pipe to see if we can give them fluids or not. We're going to check to see if they're pocketing foods, okay? They can pocket foods like in the back of their mouth. They can pocket like in their throat. We're just going to give a good look around and make sure that they aren't pocketing it back there. And then if your patient is drooling, this indicates excessive secretion, and if they can't clear their own saliva, they most likely cannot clear any food or drinks, okay? And then we're also checking for facial weakness because this can indicate that they have weakness in one side of their throat or the other. That's just harder to see visually, so we check for facial weakness. And that is all I have. That's strokes for you guys.